I thank the organizing committee and especially Professor Janak Pandey for inviting me to be here. I'm very grateful to him for this. Having gone through our neighbors' reports in numbers, I beg your forgiveness, I won't be giving any numbers about India because it's 20 times larger than the smaller countries. And if I give statistics, it will take me months together, I guess. So I will just talk about my own experience in training in clinical psychology in the country from early days and what I have learned in this course of decades of working in India. Next one. Clinical counseling and health psychology in India. From ancient times, across cultures, health and healing was embedded in the socio-cultural context. Priests, shamans, monks, and medicine men. Western medicine broke away from the practices of Hippocrates, claiming to start scientific practices. The Cartesian body-mind dualism became the foundation of Western medicine, which means Western science and medicine decided that body and mind are separate entities, so they need to be dealt separately. Hippocrates and the Indian indigenous health systems shared common constructs. For example, in Ayurveda, Trigona and Tridosha, body constitution and psychological traits, personality, the 5 elements which the organism shared with the environment. So body and mind, person and cosmos, all are one. Man is only a tiny fraction of it. So you cannot separate it. So you have a very holistic approach. So the Eastern approach, provided by all the indigenous health systems, gives a holistic approach to study of human being. History of psychological therapies in India. In the early 60s, pioneers like Surya, Neki, Hoke made bold declarations to the effect that Western training in psychotherapy was unsuited in dealing with majority of Indian patients. For example, this is a contrast to the statement of V.K. Verma, which said, after coming from abroad with the Western training, that above 90% of the Indians are unsuited for therapy. Physiology, neurophysiology. Then he became the director of All India Institute of Mental Health. And then he thought he was the brilliant mind and brain and the psychiatrist of the country of the time. He decided he was not able to change his own personality. So he left everything and went and settled down in Sri Aurobindo Ashram, continued to work as an ordinary psychiatrist. And it's not, it will take time. Okay. Then Neki was another psychiatrist who was well steeped in the Indian traditions of Sikh religion and other religions as well. And he also said, no, the model we adopt has to be very different. And he talked about Guru Shishya, or the disciple and the teacher model for treatment. And Hoke, who was trained under Medard Bose, an existential psychiatrist, came and worked in Noor Manzil in Lucknow, then in Srinagar, then in Almora, over 30 3 decades, and she said, she wrote a paper on psychotherapy with illiterates. So these pioneers actually worked with the grassroots level Indians and developed insights about it. It's still not coming? Hoch's very interesting observation was psychotherapy with the illiterates and the idiom she used. She also was very interested in shamanism in this country, spiritual healing part of the Indian culture. She studied them and she actually wrote a chapter saying process in instant cure. So she talks what happens between the shaman and the patient, how over a time of 5 minutes to 1 hour, the patient completely gets. So a lot of components of faith healing, folk healing, she covered and has done a tremendous work on sources and forces in the Indian literature and contributed. And I had the good fortune to be working with all the 3 of them. So that is where I start. And actually, Surya told me, first learn to walk among your people before you try to change them. So this was my first lesson. Western psychotherapy emerged out of Judeo-Christian traditions, while Indian therapies techniques needed to be anchored to Indian magico-religious, Buddhist, yoga, indigenous, and folk healing systems. We need to anchor them to our system because all these matter when you want to cover the entire population, not just the elitist population. Reviews of psychology have revealed much of the work in India is in replication of Western theories and practical, and all in English, Eurocentric. Pioneers like Durgana Sinha, Janak Pandey, Girishwar Mishra, Ramakrishna Rao, and others have tried to break a new ground of Indian psychology. I'm saying they have tried to break the new ground. Unfortunately, in psychology, unlike in sociology, where Professor Srinivasa's remembered village became a unique springboard to much progress on the Indian soil. Sociology is far more advanced than psychology because they are grounded to the grassroots level work. So this is where inclusiveness comes. Cultural sensitivity to diverse nature of patient population. And as we have so many languages, so many states, and so many strata in the society, starts there first, isn't it? It's coming there, okay. So how does one become culturally sensitive? I think I need the slide for a minute. I can see that one, but it will take it. So I can see it from there, but I can't see it here, which is not a good feeling. We need awareness of ethno-specific nature of Western psychotherapy and its non-applicability in the Indian socio-cultural system. Rediscovery and reformulation of indigenous therapeutic paradigms need to be looked at. And importance of personal characteristics of the therapist. This is overlooked in many models. And therapeutic interaction with the healer, the Guru-Chela paradigm. Clinical psychology training started in the All India Institute of Mental Health in 1956, and small batches of clinical psychologists were trained in research, psychological assessment, and psychological therapies. At present, there are several other institutions providing similar training, that is MPhil and PhD. But the key point was, it was a generic training providing practical experience as well as apprenticeship and supervision. This one is not coming. Okay. Now, as I was saying, that the early psychiatrists brought out models and sensitized us to need to work with the people. Unfortunately, there are several institutions in India where clinical psychologists are not allowed to do counseling or psychotherapy. I mean, something like what was mentioned about Sri Lanka. So, psychology, especially clinical psychology or applied psychology working with patients, developed in a very different way, starting with the universities and NGOs. Now, when we have so much of basic research, unfortunately, they don't have a client population, nor do they have supervisors who are trained in the subject, and supervision is generally absent. There is no chance for apprenticeship. So without practical training, reading books on clinical psychology, especially the Western books, will not enable you to deal with the kind of clients that you come across. However, there is a group of specialist trainers group, I would call them. These are practitioners, mostly trained abroad or some in India, as specific variants, there are many, of behavior therapy and esoteric methods as BMDR, NLP, hypnosis, etc. You name it, there are many, many workshops which give you training. And how many of them are evidence-based? We don't know. But it has this component that what I have, I'll give you, and you jolly well get better with it. It's not moving. Okay, training in generic skills. Training in generic skills for settings such as general hospital, mental hospital, universities, and school counseling. Generic skills are intervening, communicating effectively, maintaining confidentiality, and being empathic. Assuring suitability of the client on ego strength, social support, adverse psychosocial conditions, ability to communicate and motivate others. Indications and contraindications are focused on. Critique of counseling practice. Training is required in a special techniques and its use. It represents a global approach, one size fits all, master of one technique to cure all disorders in all the patients, time taken for counseling, expensive, require psychologically sophisticated clientele. The core component of empathy is almost redundant. Applies to very small segment of the society. I'm not saying they shouldn't be there. I'm saying they apply only to a very small segment of the society. Now we bring in the concept of health psychology and developmental psychology and positive psychology. How does it link? Psychology of the West have led to the emergence of theories and practices from positive, health, and developmental psychology. Psychology of the East takes leads from indigenous systems such as Ayurveda, Siddha, Unani, and Tibetan medicine, yoga, and Buddhist traditions, and arrives at a holistic view of health. Now, I have my own book which I have written, which is on childcare in all these medical systems. And it has such tremendous insight about childcare that we need to learn from them. So let us take health psychology. Health psychology, as practiced in India, is of recent origin and basically takes off from Western models, but rightly highlighting the importance of body-mind interaction. Embedded in the indigenous systems are the constructs of health psychology, namely seeking balance and harmony with the environment, body and mind as a single unit, primacy of Triguna and Tridosha, as the constructs on all indigenous healing systems are based on. However, Indian psychology and Indian healing systems are paid only lip service in this country. Because when I talk about it, I'm sure most of the audience here think, what is she talking about? However, psychology, but not integrated into the mainstream courses of psychology in the universities. So, which is a tragedy. Actually, under the chairmanship of Girishwar Mishra, we developed MA syllabus in psychology, integrating both East and Western concept, and that has not found any customers in any of the universities. So Indian psychology remains alien. Though many, many pioneer workers have worked on it, it doesn't reach the student population. Positive psychology. A shift of focus from ill health to well-being, resilience, creativity, and spirituality. Indian Pan-Asian vantage point, indigenous health system focus on promotion of health, religious practices, folk practices, and social rituals. All have equal role to play in promoting health. Developmental psychology, life cycle approach, Western theories and practices, developmental phases from conception to death, life cycle approach, importance of biological and psychosocial contribution, continuity and discontinuity in development. In the indigenous practices, we have samskaras or rites of passage or equivalents in other religions. And there are developmental phases which are part of healing systems, social customs, and traditions. So even the naming ceremony, the wedding, everything is part of the ritual, social ritual, which also takes into developmental phases. There are 16 developmental phases in the Hindu ethos, which is fine-tuned to what trajectory should be set for the infant when he grows up to become an adult, and so on. How do we bridge the gap? That's the key point here. Cultural sensitivity in counseling to cater to the need of most Indian clients, what you should aim at. De-emphasize on a single method approach based on techniques developed in the West, which are expensive, require training, it does not need me. One size doesn't fit all. The best of techniques to bridge the gap. What do we have in the Western armamentarian? I would consider supportive psychotherapy or supportive techniques are the most suitable for this country, for majority of the people. Because these vary according to cultural context and is holistic in approach. Supportive psychotherapies, you can choose any which you like. What are the supportive techniques? Reassurance, lot of folk healing rituals, reassurance, suggestion, environmental manipulation, part of folk and religious traditions, psychoeducation, contemporary practice, counseling, family, spouses, child, etc., developmental psychology, remediation, rehabilitation, contemporary practices, encouragement and praise is behavioral, strengthening adaptive response and desensitization behavior, emphasis on strengths and talents, positive psychology, emotional catharsis, insight-based. So it is eclectic and it's holistic. So we need a paradigm shift. We need to combine best of the both worlds. There is a need to cultural sensitivity to enhance cultural competency. We all talk about competencies among psychologists, but cultural competency is most needed, and that's what we need them to have. Indigenous psychological constructs of Triguna and Tridosha, highlighting individual differences in a particular developmental context, need to be employed. For example, in Ayurveda, the fetus is sensitive, aware, capable of feeling, has a mind. So obviously when the baby is born, he is ready. That is the latest in developmental psychology, that at birth the child is ready to learn everything, including language, etc. So these ideas are embedded in the indigenous systems. Use of multiple methods tailored to the needs of individual, family, society is essential. Multiple symptoms with multiple etiologies. Now, etiologies are very important. Need to develop multiple techniques, especially supportive techniques. Eclectic approach is not necessarily an ad hoc one. Eclectic and holistic approach based on cultural sensitivity brings out the best of Western and Eastern approaches. Thank you.